Hello and welcome to the St. Michael Medical Center Weight Loss Surgery Seminar. This presentation will serve as a basic introduction to the weight loss surgery program. My name is Kevin Clive and I'm a general and bariatric surgeon at St. Michael Medical Center located in Silverdale, Washington. I received my medical degree from the University of Cincinnati in 2007 and completed my general surgery training at San Antonio Military Medical Center in 2013. I am currently a fellow of the American College of Surgeons and a member of the American Society of Metabolic and Bariatric Surgeons. I spent 11 years in the Army caring for soldiers and their families and transitioned to my current practice here at St. Michael in 2018. The purpose of this seminar is to provide you with a basic knowledge of our multidisciplinary weight loss surgery program. Our mission is to provide a comprehensive approach to address your healthcare needs. This is achieved through a foundation of nutrition education, physical therapy support, and behavioral modification through our behavioral health resources. Patient safety remains the top priority throughout our program and is the driving force behind the preoperative processes to include diagnostic studies and procedures. Ultimately, we aim to ensure that we give our patients the best chance at long-term success while helping them to achieve their health goals. We believe that this process will allow our patients to lead happy and healthy lives without a need for additional procedures. In order to understand the qualifications for weight loss surgery, we first need to define the criteria. Body mass index is a crude measurement of weight to height ratio and serves as the basis for who meets criteria for weight loss surgery according to the National Institute of Health, as well as insurance providers. BMI does not take into consideration an individual's age, sex, race, or muscle mass. It is not a direct measure of body fat. However, increased BMI is associated with increased risk for other chronic health conditions. The BMI is calculated by dividing the weight in kilograms by the height in meters squared. The same calculation using weight in pounds and height in inches is listed here as well. The World Health Organization defines classes of obesity based on BMI, which are demonstrated here in bold. Note that Class 1 obesity is a BMI of 30 to 35, Class 2 obesity BMI of 35 to 40, and Class 3 obesity is a BMI greater than or equal to 40. Who typically qualifies for weight loss surgery? Patients with a BMI greater than or equal to 40 and those with a BMI greater than 35 with a coexisting medical condition such as diabetes, hypertension, obstructive sleep apnea, fatty liver disease, joint disease, high cholesterol, reflux disease, heart disease, and others. Most insurance providers include requirements for documenting failed attempts at weight loss through diet and exercise. It is critical that women of childbearing age avoid pregnancy for 2 years after surgery due to the potential risk to the fetus during a period of caloric and nutrient deficiencies. Finally, it is mandatory to abstain from all tobacco and nicotine products to avoid postoperative complications and promote a healthy lifestyle. The multidisciplinary pathway to weight loss surgery starts with completing the educational seminar here. The order of the steps listed here may vary slightly depending on the patient and their insurance carrier. Following the seminar, I usually will see patients in the office to review their medical history, perform a physical exam, discuss surgical options, review insurance requirements, and lay out their individualized pathway based on the overall evaluation. Patients leave that visit with a checklist of appointments and tests to be performed prior to surgery. Once the program and surgery requirements have been met, patients will complete pre-surgery studies, which are based on their medical history. These will be discussed further in a later slide. After obtaining these studies, the patients will meet with me to review results, discuss treatment goals, and determine which procedure is most appropriate. Surgery will be scheduled at that visit. After surgery, a short hospital stay, patients will have scheduled follow-up with myself. Additional follow-up with nutritionists, physical therapists, and obesity medicine specialists are available as needed. It is important to understand that some insurance companies require prior authorization before any visit with their surgeon, and some of them are listed here. Some insurers also have contracts with certain hospitals, and those patients may be required to undergo surgery at one of those facilities or consider other options for insurance or payment. St. Michael Medical Center currently has a strict inclusion criteria for surgery candidates while we strive to attain Center of Excellence accreditation. These exclusions are not indefinite and exist only to further ensure the safety of our patients. For patients older than 65 that exceed the listed BMI threshold, have significant medical problems to include organ failure, transplant, cardiorespiratory disease, are not ambulatory, or are requiring complex revision surgery, you may be referred to our Center of Excellence program located at St. Francis in Federal Way. Let's further discuss the preoperative evaluation. As I stated, all patients will undergo nutrition education in preparation for surgery, have a behavioral health evaluation to rule out any contraindications for surgery, and receive evaluation by physical therapy to assess physical limitations and provide options for a healthy, active lifestyle before and after surgery. Patients also will meet with Dr. Garza or Dr. Sutherland, our obesity medicine specialist, for assistance with medical evaluation optimization in the perioperative period. Many patients may require evaluation by our sleep medicine specialists for sleep apnea treatment. If you are currently being treated for this and are actively followed by a specialist, this will not be necessary. Patients that experience pain in the right upper abdomen after eating or at regular intervals will be assessed for gallstones using an abdominal ultrasound. This problem can be addressed at the time of surgery if necessary. All patients will be evaluated with a swallow study to look for a hiatal hernia. This is performed by drinking a contrast agent that shows up on X-ray and can demonstrate a hiatal hernia that may have otherwise been missed on endoscopy or at the time of surgery. Having this information allows me to plan surgery appropriately. Finally, upper endoscopy is performed by placing a flexible tube with a camera through the mouth, down through the esophagus and stomach, to the level of the first part of the small intestine. This is done under sedation, usually lasts about 10 minutes, and allows for detection of changes from reflux disease or other less common diseases that may change the type of surgery recommended. The typical surgical procedures for weight loss are listed here, and we will discuss further in the following slides. My preferred surgical approach is utilizing the robotic platform, which is similar to laparoscopy and uses 5 to 6 small incisions with long instruments and a camera. This allows for less pain and a shorter recovery. It is unusual to have to perform open procedures through large incisions, but the possibility for this is always discussed prior to surgery. The first procedure we will discuss is the gastric bypass. This has been considered the gold standard procedure for weight loss because of its effectiveness and durability. The procedure involves creating a small gastric pouch and connecting a limb of small intestine to this pouch. This is called the roux limb. This limb is then connected to the small bowel downstream to allow for communication of the food channel with the digestive enzymes, where nutrition may then start to be absorbed. This manipulation of the small bowel creates changes in the anatomy that allows for risks we will discuss on the next slide. Because of the small gastric pouch and the bypassed area of small intestine, this procedure is restrictive and malabsorptive, meaning that it limits the amount of food consumed at one time and the amount of nutrition that is absorbed. The main benefits of this procedure are that it allows for sustained weight loss as demonstrated in long-term studies following patients for 5 years or more. Patients, on average, will lose approximately 75% of their excess weight or 35% of their total weight. The bypass procedure has also shown to have cure rates of 75% for hypertension, 80% for diabetes, 85% for hyperlipidemia, also known as high cholesterol, 75% for obstructive sleep apnea, and 95% for gastroesophageal reflux disease. Some of the potential risks associated with the bypass procedure include the risk for leakage from one of the staple lines or new bowel connections, bleeding from these staple lines or new connections, Patients may also develop ulcers at the connection between the gastric pouch and the small bowel, known as a marginal ulcer. This is more commonly seen in patients that use chronic NSAIDs like ibuprofen or Motrin and chronic tobacco users. This is one of the many reasons we insist upon tobacco cessation. Sometimes patients may develop what is called an internal hernia, which occurs when the bowel gets caught up in or under the spaces that are created when we manipulate and rearrange the anatomy. Patients describe an acute onset of abdominal pain that is often associated with symptoms of a blockage. Bariatric surgeons remain vigilant with making this diagnosis and may need to return to the operating room to correct this problem. Incisional hernias can also develop at the site of any incision. Blood clots may develop in the legs or lungs. Injury to the spleen may require removal of this organ. Gallstones may develop in conjunction with rapid weight loss. Patients' blood sugars may be too low. This is known as hypoglycemia. Dumping syndrome may occur, and this is due to rapid emptying of the food from the small gastric pouch into the intestine. This often occurs when patients consume a higher sugar load, often in a liquid or easily absorbed form, and this leads to symptoms of abdominal discomfort, nausea, diarrhea, sweating, flushing, and a racing heart. This is usually managed with dietary modifications. Finally, as many as 50% of patients may experience chronic nutrient or mineral deficiencies, such as iron deficiency. For this reason, we recommend lifelong supplementation with a multivitamin with iron and additional supplements as needed. We monitor for this throughout patient follow-up. The next procedure we will discuss is the sleeve gastrectomy. This is currently the most common procedure performed for weight loss surgery. The procedure is purely restrictive, meaning that it limits the volume of food that can be consumed at one time. This is accomplished by using a surgical stapling device and removing the outer portion of the stomach. This is sometimes used as the first stage of a two-stage procedure for super obese patients. Next, we'll discuss the risks and benefits associated with the sleeve gastrectomy. Patients can expect approximately 65% excess weight loss, or approximately 30% total weight loss. Cure rates associated with the sleeve gastrectomy include 65% for hypertension, 60% for diabetes, 75% for hyperlipidemia, 60% for obstructive sleep apnea, and 75% for gastroesophageal reflux disease. Of note, the stomach still functions normally, and the procedure has a minimal impact on other anatomy without the risk for internal hernias. Some of the risks that we described with the bypass procedures still pertain to the sleeve gastrectomy, to include a risk of leak from the staple line, risks of bleeding from the staple line or the surgical site, a risk of narrowing of the stomach or stenosis with an incidence of approximately 3.5%, development or worsening of reflux disease, and development of blood clots in the legs or lungs. The duodenal switch is the least commonly performed of the bariatric procedures we will discuss and combines the sleeve procedure with a long bypass component. This is usually reserved for those patients with superobesity and has been shown to provide the most weight loss, but has also been associated with the highest complication rates. Next, we'll discuss the risks and benefits associated with the duodenal switch procedure. This procedure has been shown to have approximately 80% excess weight loss, or 40% total weight loss. Cure rates associated with the duodenal switch include 85% for hypertension, 90% for diabetes, 90% for hyperlipidemia, 75% for obstructive sleep apnea, 75% for gastroesophageal reflux disease. The duodenal switch has been shown to be the best at controlling difficult to control diabetes, and this procedure may be performed after having a prior sleeve gastrectomy. The risks associated with this procedure are similar to the aforementioned procedures, to include leaks, bleeding, blood clots, bowel obstructions, strictures, hernias. Risks that are more specific to this procedure include excessive weight loss, nutrient deficiencies, and life-limiting diarrhea. The adjustable gastric band is a device placed around the upper stomach, with a connecting port located under the skin, allowing for adjustments to the amount of food that can be consumed at one time. While I do not place adjustable gastric bands, I often will manage them if they've been placed previously by filling or removing fluid from the band, depending on the patient's symptoms and weight loss goals. It is not unusual to have to remove these devices or to convert to other weight loss procedures. My reasons for not placing them include the low success rates for sustained weight loss and the long term risks associated with them, to include band slippage, progressive reflux disease, and the potential for the band to erode through the stomach. The typical hospital stay after surgery is 1 to 2 days. The patient and healthcare team have a clear set of expectations during the hospital stay, as well as discharge goals. These include mandatory ambulation within 4 hours after surgery to minimize the risk for development of blood clots. We want to make sure that our patients are well hydrated and can safely consume more than 1.5 liters or 50 ounces of clear liquids within a 24-hour period. Dehydration is a common issue after surgery and can cause unnecessary returns to the hospital if patients are not prepared prior to discharge. Finally, we want to ensure that our patients' pain and nausea are controlled on the regimen made available in the hospital, which will also be made available to them after they are discharged. The typical post-surgery follow-up is listed here. Dietary tolerance and advancement will be assessed at the first follow-up appointment, and nutrition labs will be reviewed at each subsequent visit. Weight loss surgery patients benefit from annual follow-up with their surgeon indefinitely, which allows for careful monitoring of nutrition status and management of any recurring issues. I want to thank you for your time and congratulate you for taking this first step on your journey toward health. If you have any questions for me, please do not hesitate to contact me via email, call my office, or reach out to me via MyChart. Weight loss surgery services available within the CHI Franciscan system are provided at the locations listed here. Again, thank you and best wishes.